to introduce our presenter for today, Dr. Jennifer S. Harthan. She is a Fellow of the Academy of Optometry, Fellow of the Scleral Lens Education Society, and Diplomat of the American Board of Optometry. Dr. Harthan is currently an attending optometrist and associate professor, as well as the chief of the Cornea Center for Clinical Excellence of the Illinois Eye Institute, where she works with both students and residents from the Illinois College of Optometry. Dr. Harthan is one of the developers of the InSight Scleral lens and is here today to discuss how to select initial lenses based on history, cornea profile, and topographic analysis, and share some of her clinical insight success stories. The title for her presentation today is Gain Insight to Easy Scleral Lens Fitting, Part 2, Clinical Applications for the InSight Scleral. I'm now going to turn it over to Dr. Harthan.
Thank you for that great introduction, Laura. I would like to welcome you all to part 2 of our webinar series on the InSight Scleral lens. This webinar, we're going to focus on when and where the InSight Scleral lens is most appropriate. And if you missed part 1, you can view it online at metrooptics.com. Here are my disclosures. So our objectives for this discussion are to understand the InSight Scleral lens design and its applications for both the regular and irregular cornea. We're going to briefly review how to select initial lenses based on history, corneal profile, and topographic analysis. And we're going to spend most of our time reviewing clinical cases with anterior segment photography and videography to fully comprehend how this lens can be utilized for cases beyond presbyopia. So there are so many great scleral lenses out there. So what is unique about the InSight Scleral lens? The InSight Scleral lens featuring HHM technology is a distant center multifocal, and this was designed to maximize both comfort and vision across the full spectrum of vision needs, including nearsighted individuals, farsighted, astigmatic, presbyopic, ocular surface disease, and irregular corneal patients. The ultimate goal in designing this lens was to optimize vision, comfort, and ocular health for the patient while reducing chair time for the practitioner. The InSight Scleral lens is a multifocal option for normal corneas, irregular corneas, and can also be fit for oblate corneas. So those patients who are post-surgical, those individuals who have had refractive surgery, who have undergone intakes and corneal transplants. The basic fitting set has a +1 add built into it, and a great feature about ordering the lens is that there are unlimited warranty within a 90-day window, and there are no additional fees for any add-ons, such as toric haptics or front surface toricity. So here are the available parameters. Sphere power is unlimited. Still power is available from 0.25 to -8 in a quarter diopter steps. Axis is available 0 to 180 and 5-degree steps. The add power, again, is a distant center, and it goes all the way up to a +3. The standard diameter for this lens is a 15.2 or a 15.6, and most patients can be fit in these diameters. However, if we need to, we can customize it up to an 18. The standard periphery is a 1250 radius. A flat 1, flat 2, or flat 3 can be ordered. A flat 1 has a 13 millimeter radius, a flat 2, a 13.5 millimeter radius, a flat 3, a 14 millimeter radius. You can also order it in steep radius. A steep 1 is a 12 millimeter radius, a steep 2 is 1150, and a steep 3 is 1100. And you can also customize toric peripheries as well. So we've heard a lot of feedback about this lens, and overall it's been doing great, but some individuals are like, well, this is a multifocal lens, so what if the patient is not presbyopic? Well, the InSight lens provides benefits beyond presbyopia. We have heard a lot in the media and in recent publications about digital eye strain. More and more individuals are not only spending increased time on digital devices, but many individuals have more than one digital device. And as we spend more time on these, this can lead to blurred vision, dryness, eye strain, fatigue. By providing the patient with additional reading prescription, this alleviates some of their strain. So not only does the InSight work well for presbyopic patients, it works well for those who don't need the presbyopic add. So many patients have been successful with InSight Scleral clinically. We have used this lens for patients with uncomplicated refractive error, those who are nearsighted, farsighted, astigmatic. For irregular corneas, those individuals with post-hydrops, keratoconic, very uneven grafts, those who are post-LASIK, refractive surgery, those who have undergone corneal cross-linking, what this lens allows is for increased wearing time, reduced corneal staining, and improvement in vision. Those patients with damaged or diseased ocular surfaces, those with Stevens-Johnson syndrome, Sjogren's disease, graft versus host disease, this lens can be very instrumental in reducing further damage, as it serves as a tear reservoir to allow corneal healing and improve vision. We spent a lot of time during the first webinar reviewing how to select the initial lens, as well as how to properly evaluate the fit. I'm going to briefly review this so we can spend the rest of the time reviewing clinical cases. But essentially, how we determine the base curve is if a patient has less than 2.5 diopters of corneal sill, we select a base curve 0.4 millimeters steeper than flat K. If a patient has corneal cylinder greater than 2.5 diopters, we select a base curve 0.3 millimeters steeper than steep K. And for those patients who have corneal ectasia or post-surgical, for any amount of corneal cylinder, we're going to select a base curve 0.3 millimeters steeper than steep K. Now for some patients, as we know, sometimes K readings are unobtainable, whether that be due to corneal scarring, poor tear film. If that's the case, start with a base curve of 7.2 or look at corneal profile. So when we're looking at topography, it's important to look at the K value using the tangential map, determine the HVID, look at the shape, size, as this can be helpful in determining what diameter we're going to select. If a patient has a HVID of less than 11.5, we're going to use the 15.2 diameter. If a patient has an HVID of 11.5 or greater, then we're going to select the 15.6 OAD. And again, looking at corneal profile, you can use this with a transilluminator or by moving your slit lamp arm. This is going to work well with any lens, scleral lens set that you have. Look at the profile. You can select a scleral lens from your fitting set, and you want to make sure that the lens is vaulting a little bit more than your corneal profile. When evaluating the lens, an ideal fit centrally is going to have a 1-to-1 fitting relationship between the thickness of the lens and the thickness of the post-lens tear layer. This is going to be equivalent to about 150 to 250 microns of clearance. Now the center thickness of the InSight scleral lens is going to be anywhere from 0.25 to 0.38. And we see that increased thickness for the higher plus lenses. So those lenses that you have +6 to +8 range, they're going to be a little bit thicker. For a standard lens, it's going to be about 0.25. An ideal fit for limbo clearance will have slightly less clearance than observed centrally, really looking for about 50 to 80 microns of clearance, and thus just noticeable fluorescein. So when looking at the limbus must be cleared with fluorescein. Compression at the limbus could damage the delicate stem cells. So how do we observe whether or not we have proper evaluation, proper vault over the limbal area? We can do this one of two ways. We can observe with optic section and with fluorescein. When we're looking with optic section, we should be able to perceive clearance, be able to notice that fluorescein, and overall the fluorescein should obscure the pattern. You can use an OCT, but many clinics do not have that, and it's not necessary. When assessing the edge, or the scleral haptic, an ideal fit will land evenly on the sclera, not having any blanching, not having any standoff or lift, the full circumference of the lens. An uneven fit may require a toric periphery. So when evaluating the edge of the lens, you want to document the clock hour position and severity, and you can also utilize consultation, as they are very helpful in determining how you need to modify the scleral haptic of the lens. Essentially, the edge of the lens should look like a well-fitting soft lens. What I find helpful when evaluating these lenses, any scleral lens, is to rotate the lens manually with your finger, making sure it does not catch in any area. So this is taking a look here at a patient, the very edge of the lens. And we can notice inferiorly that it looks pretty decent, but when we look superiorly, it's fine, but temporally right there we see a little bit of blanching, a little bit of impingement. It's just minor, and it may be okay, but as the patient wears the settling, we may see more compression in that area. So again, this patient may do better with a toric periphery, flattening it in that horizontal meridian. So it's also important to monitor these patients, let the lenses settle. When you see these patients back on follow-up, make sure that they've had the lenses on for several hours. So what I really want to do for the remainder of our time is spend some time looking at some cases. And again, looking at what can we do with this lens to benefit the patients that we see clinically. So the first patient is a 22-year-old who presented for a fitting. She was diagnosed at 4 years of age with strabismus and currently wears progressives. Medical history is unremarkable, and other than the strabismus, she is hyperopic and does not take any medications. Through her corrected acuities, she's 20/20ths in both eyes, and here you can see her refraction. She's hyperopic with astigmatism, and then she does wear an ad. Now she currently wears soft lenses, but notices that the soft lenses are not stable for her, and that they tend to rotate throughout the day, and as she's studying, she tends to get more fatigued. So she was interested in pursuing being fit with the lens. Now this patient, because she does wear an ad to help with her binocularity, she did benefit from the lens. Now taking a look here at her topography, we can see her Ks are 4480 by 4672. So she has about 1 3/4 diopter of corneal sill. It's more oblique. She does have larger pupils, and her HVID is 11.5. And with her left eye, she has about 1 3/4 diopter of corneal sill, pupil size 7, and her HVID is 11.4. Now she does have larger pupils, and that's something also to kind of watch as we're fitting these lenses. Sometimes patients with larger pupils will notice some glare and halos, but we can also customize the optical zone with these lenses as well, just so that the patient has as least distortion as possible. So this patient, we fit her with this InSight lens, and she was doing quite well, 20/20 in the right eye, 20/20 minus. With the ad that she needed, we found that she only needed about a +150. Now, if you take a look here in an optic section, you might notice, looking at the thickness of the lens to the thickness of the post-lens tear layer, you might say that the thickness of the post-lens tear layer isn't adequate. Well, remember, secondary to the higher plus lens, it's thicker. So her post-lens tear layer is adequate. She just has a thicker lens. So what we did is we reduced the center thickness of the lens to have a more equivalent 1-to-1 relationship to allow more oxygen transmission. Taking a look here at the periphery, we have adequate landing of the scleral haptic. And then here we can see that we have nice even tear exchange centrally. And she's been wearing the lens now for about a year and is quite happy overall with her vision and comfort, and is finding less fatigue throughout the day as she's getting more stable vision, less aberrations, less rotation with the sclerals as compared to her soft lenses. Now this next patient was challenging, and for those of you who do see patients with intacs, I think that these sometimes can be one of the hardest types of patients to fit. This is a 30-year-old Hispanic female who presented for a contact lens fitting, diagnosed with keratoconus 5 years prior. She had previously tried gas permeable lenses, but was not able to wear them secondary to comfort. She had had intacs 8 months ago. One of the ophthalmologists that we work with, he does quite a bit of intact surgery and then sends them to us for fitting. And one of the challenges, again, of the intacs is to make sure that whatever type of lens that we're fitting them with is that they don't have any mechanical rubbing on them, as that can cause extrusion and neovascularization. We also want to make sure that we have lots of oxygen transmission in that area. Patient medical history was remarkable for allergies. She also has dryness issues, and she does take Allegra as needed for her allergies. So she's been walking around for the last 8 months Uncorrected, since she had the intact surgery, seeing 28 hundredths in the right eye and 24 hundredths in the left eye. Refraction with higher amounts of myopia and low amounts of astigmatism, we were only able to improve her to 21 hundredths. So we had a long conversation with her about the different types of contact lenses that were available to her, what the care and management as well as the follow-up. I think that's very important whenever we're fitting a patient with any type of lens, in particular a scleral lens, really making sure that the patient is motivated, not only in terms of taking care of the lens, but in terms of coming in for follow-up to make sure that there aren't any potential complications down the road, making sure that they're on board with what we're trying to accomplish. When we take a look at her topography, even though she's, post-intact, sometimes we will see more of an oblate shape. But really what they're trying to accomplish by putting in intact, sometimes they'll insert 2 of the stromal rings, sometimes they'll just do 1. And in this case, the surgeon only implanted 1 in each eye. But they're trying to make the cornea a little bit flatter. But with the intacts, her Ks are 50 by about 53. So she has 2.5 diopters of corneal sill. And what also we want to look for with these patients is look at their corneal thickness. So her corneal thickness, the minimum was 380 microns in the right eye, as well as in the left eye. She's about 380 microns thick. And her corneal sill in this eye was almost 2.5 as well. So with her lenses, these lenses were fit a little bit steeper just based on her corneal curvature. And one thing that you can appreciate is you can see the intacts inferiorly, and then the key thing as well is we want to make sure that we have adequate amounts of clearance tear exchange, not only initially but also after 20 minutes of settling, several hours of settling. But what we also did with her lenses is we had the lenses hydropegged because she had problems with dryness and allergies. And for those of you who are unfamiliar with hydropeg, hydropeg is a 90% water polyethylene glycol-based polymer mixture that we can permanently bond to the surface of the lens. What this does is it improves the wettability, lubricity, surface water retention, and tear breakup time to minimize friction and lens deposition. So this is a great option for patients with poor surface wetting, lid disease, comfort issues, dryness, and those patients who experience fogging throughout the day. The big thing that we need to educate patients about for those who are going to hydropeg their lenses is to talk to them about handling and solutions that they need to use, as the lenses can be more slippery when handling, and they also need to avoid cleaners with alcohol, as that can strip the hydropeg. So recommended solutions for hydropeg lenses are clear care and unique pH. Another thing to keep in mind is that if you are fitting scleral lenses for patients who have leg ophthalmos, those patients who tend to have heavy deposits, if you hydropeg the lenses, it tends to have a shorter duration of effectiveness for those specific patients. So going back to this patient here and looking at the parameters of her lenses, what we had to do with her is our standard limbal curve on the InSight lens is a 1040, but to make sure that we had enough clearance over the very edge of where the intact sat, we had to steepen the limbal curve a little bit, and that's why we went to the 1030 limbal curve. We also had some compression at the very scleral haptics, so we went to a flatter peripheral. We went to a flat 1, so we went to a 13.0 peripheral curve. So she was doing very, very well. She's 20/20 in the lenses. She's thrilled with them. And then after about 2 hours of wear, we can see that we don't have as much clearance. So for her final lenses, we did increase the overall vault by an additional 75 microns. But these lenses can be, and these types of patients can be very difficult to manage. And again, the big thing is just to make sure absolutely no mechanical rub, make sure that we have enough tear exchange. Here you can see with her OCT, nice tear exchange. We have about 280 microns of clearance throughout, and here you can see the intacts, no touch here. The left eye, we only had about 140 initially with that one, so that's where we increased it by an additional 100. And then again, no touch, here we increased it as well. And here is, it's compressing at the very edge, so that's why we went to the 1300. And as you go along, if you have any questions about any of these cases, please feel free to shoot us a question, send us an email. We'll try to get to all of your questions at the end. If for some reason we don't, we'll make sure to answer those all at the end. Our next case is a patient who presented for a fitting status post cross-linking. Some of you may be seeing more and more of these patients now that epi-off corneal cross-linking is FDA approved. So this patient was diagnosed with keratoconus in 2010 and then had corneal cross-linking in May of this year. Medical history, he's diabetic, hypertension. He has worn a variety of different lenses in the past. We had talked about actually fitting him with scleral lenses prior to him being cross-linked, but secondary to him progressing in his visits, we had recommended that he get cross-linked first and then return for the evaluation of the fitting. So uncorrected acuities when we saw him post cross-linking was 22 hundredths in the right eye, but he was able to pinhole the 21/25. Uncorrected acuities in the left eye was 20/60ths. He was able to pinhole the 20/30ths in the left eye. Refraction, you can see the large amount of astigmatism, 6 diopters in the right eye, able to correct him to 20/80ths in the left eye, 4 diopters, and that corrected him to 20/25ths. And as we know, trying to correct this in a pair of glasses is going to give him significant distortion. So that's why contact lens is a more appropriate option. Going over, again, all the different options with him, he did elect to be fit with the scleral lens. Taking a look at his topographies, what's interesting, if we look at his Ks pre-cross-linking, they were 55 1/4 by 63 1/4 in the right eye. So he had about almost 8 diopters of corneal still pre-cross-linking. And then post-cross-linking, he was 53 3/4 by 59, so he was down to 5.31 diopters of corneal still post-cross-linking. So he had stabilized quite a bit just in that short period that we had seen him. And his minimum Pachy's at this time were 351s. So normally for them to have epi-off cross-linking, they have to have a pachymetry of 400, but he at this visit was 351. And you can see that he's more of a central cone, a little bit inferior oval. In his left eye, his Ks pre-cross-linking were 4180 by 45, so his left eye was not as advanced, and he had only about 3 1/4 diopters of corneal still pre-cross-linking. His Ks post-cross-linking were 4150 by 44 1/4, and his corneal still post-crossing was about 2 3/4 diopter, and his minimum Pachy at that time was 464. Again, this here you can see that his curvature, his keratoconus is a little bit more inferior, but he would do quite well with a scleral lens. So part of it was, you know, because of his age, did we have to necessarily go with a multifocal at this point? We didn't. But we talked about the benefits and we talked about the pros and cons of different types of lenses. So we did decide to go with InSight lens. We fit him with a 680 base curve, a -450 power. With him, he did have a little bit of a larger HVID. So we elected to go with a 15/6 diameter and then included a +150 add. Now with his initial lenses, we did not hydropeg them, but he did have some problems with dryness. So for his final lenses, we did add the hydropeg coating to them, and then he did find that he had less fogging. He did have improvement in dryness. For his left eye, because that eye is not as advanced. He has a flatter base curve of a 750, a minus 350 power, 15.6 diameter, and an add of a 150, and he's 20/20 in that eye. And sometimes when you look at these scans, you'll see a little bit of an artifact defect. Sometimes that is from just the patient moving. But you can see that we have 260 microns of clearance in the right eye and 210 microns of clearance in the left eye. And this is after several hours of wear. Again, when we see these patients back for a follow-up, I always recommend to see them. What was interesting, though, with this patient is as we saw him back for his 1-month follow-up, he had more compression of the edge. So what we did to alleviate that, if you look here, you can see slight compression here, a little bit. We changed to a toric flat one, so we flattened that horizontal meridian just slightly to alleviate the slight compression. And he's doing great now. But again, take a look at those patients after they want to see him back at a different time of the day. Also, remove the lenses when you see the patient back on follow-up and instill some fluorescein stain. If you see any areas of staining on the limbus, on the conjunctiva, that probably is a good indication that we need to modify an area of the lens. This next case was referred for specifically a scleral lens fitting. One of the cornea specialists that we work with, we've been trying to do a lot of networking in our clinic, reaching out to some of the cornea specialists, letting them know some of the services that we provide. We send patients there for surgical consults, and they've been sending them back for scleral lens fits. But this patient was referred to us specifically for a scleral lens fit. Patient was diagnosed very young age with Meesmann's corneal dystrophy. For those of you who aren't as familiar with Meesmann's, it's a dystrophy that affects the epithelium and the basement membrane of the cornea. Early on, patients typically have irritation and photophobia. We will see surface irregularities and epithelial cysts, and sometimes those will coalesce to form refractile lines, and it becomes more opaque over time. Usually with Meesmann's, the Bowman's and stroma are unaffected. So the patient came in reporting that her cornea had been scraped many times. She had tried steroids and other drops, but her vision was still blurred. She has tried soft lenses and GP lenses in the past. What's interesting to note also with Meesmann's is that patients typically have decreased corneal sensitivity. So that's another thing to keep in mind when fitting them, not just with sclerals, but with any type of contact lens, is they have reduced corneal sensitivity, so they may not be as aware as how things feel. If they get something in the eye, or they may have some irritation that other patients may experience, it may not be to the same level. So really we want to do close follow-up with these patients initially. Patient had an aneurysm in the past. She has high cholesterol, also experiences dry eye, uses some over-the-counter artificial tears. She was not using the correct things. We try to get her back on track with that as well. Systemic medications that she's taking was gabapentin and Lamictal, and she was slightly hesitant to try the new lenses, but she was told that the contact lenses would protect the cornea. So ultimately she said, I will try it if you think it'll help. So we, discussed with her what the scleral lenses do. We showed her what they looked like. We let her actually feel the scleral lens, and she was like, wow, this is huge. I can't believe I'm going to put this on my eye. But eventually she did decide, let's try it. So her entering acuities corrected weren't that horrible in the right eye. She was 20/25. In the left eye, she was 20/70 minus. She did have a little bit of hyperopia, a little bit of SIL, and she did need that add. She was 20/20 in the right eye and 20/40 in the left. But I think what's really interesting to take a look at is her topography, and you can see how highly irregular her corneas are. She doesn't have a lot of corneal sill. She only has about 3/4 of diopter of corneal sill. but she is highly irregular. And she noticed a lot of distortion. And what's nice here in our topographer that we have one of our settings set for image simulation. So sometimes these patients will come in with their families, and sometimes the families don't necessarily understand what the patient is going through. So we can then talk to them and show them what the patient is seeing, and they have a better idea of what the patient is actually dealing with. So a lot of distortion, you can see a lot of irregularity. She's steeper, almost, you know, she has this little central island. Same thing with the left eye, highly irregular, only about 3/4 of diopter of corneal cell. She does have a larger HVID, 13 millimeter. Now normally with her, we started off with just a 15-2, and the reason why is because of the base curve that we wanted to select. And she was a little bit intimidated by the diameter. So, and again, we should have started with the 15-6, but she was just intimidated. So when we were starting to order, we started with the 15-2, but she should have been started with a 15-6. So we needed the toric front surface as well, just to help improve the vision. What was also interesting that with the initial fit, and this I'll tell you is where we went wrong, is we didn't let her settle enough. Sometimes in a busy clinic, it's very easy to just keep the patients moving, but I will tell you with this case, this is where it burned us. The peripheries had slight shadows. When you see slight shadows, that often indicates liftoff. So we ordered it with a steep 1 peripheral system, a 1250 edge, whereas if we just would have let her sit and settle over time, we would have seen what was happening, and I'll show you the images in just a second. But so with her, we needed a front surface toric in the right eye. She did need the ad, and you can see here she also had more clearance, but again, if we would have let it settle, we would have seen an improvement. But look here, she had some compression, and you can see right at the limbus the lenses aren't larger enough. So we reordered the periphery standard with a larger overall diameter, and that solved the problem. So if you just take the time, let these lenses settle, do what's in the best interest of the patient, it'll save you a lot of time. So again, we're in a busy clinic, we work with a lot of students, a lot of residents, and we make very stupid mistakes. So this could have saved the patient a trip and us a reorder if we would have just followed our own recommendations. But those things happen. So just take time, take a look, stain, let the lenses settle. Sometimes what we'll recommend patients do, you know, is go read a magazine, walk around. If you want to go grab a cup of coffee, go grab a cup of coffee, then come back, and that's helpful as well. This next case was a little bit challenging as far as communication as well as follow-up. She was referred by one of our corneal specialists for a fitting. She reported that she had multiple surgeries in Mexico to correct her astigmatism, and that was done in 1992, and then she had her most recent one in 1998. Sometimes, as you know, trying to get a very detailed, accurate history on these patients can be somewhat challenging. So in the end, we really weren't sure how many surgeries she actually had on each eye. It was quite difficult, but what was interesting is her complaint is not only did she complain of blurred vision, some distortion, but she also had some pain upon awakening. Throughout, you know, the course of when we fit her to waiting to her lenses to come in, she also had some episodes of recurrent corneal erosions, so that addressed why she was having the pain upon awakening. So not only did we have her cornea astigmatic component to deal with, but we also now have this recurrent corneal erosion. So she has dry eye issues, recurrent corneal erosions, and then her irregular astigmatic corneas to deal with as well. Her corrected acuities coming in at the time of the fitting was 20/30 in the right eye, 20/40 in the left. She has a moderate amount of hyperopia with some astigmatism, and that only improved to about 25ths in each eye. And her topography, as you can see, irregular. She's steepening inferiorly, flatter, more oblate. But again, she has a steep band in the center here. She has about 2.5 diopters of corneal sill. And, you know, taking a look here at this inferior elevation, that, you know, was what we really needed to pay attention to when fitting, not only with the cornea, but also, you know, that addressed how we needed to modify the limbal area of the lens as well as the scleral haptic of the lens. Her left eye, again, very irregular. She's steeper superiorly and inferiorly, which made sense with her, you know, history of multiple corneal surgeries to correct for her astigmatism. So we suspected that she had some type of refractive surgery. This eye, she has almost 2 diopters of corneal astigmatism. So with her lenses, we initially started with a 7.4 base curve, a 15.6 diameter in the right eye, a 7.2 base curve in the right, a 15.6 diameter in the left, and we did have to go to a +3 at. Now we have adequate 1-to-1 central relationship, a little bit less in the right eye, but adequate in the left eye. Now what's interesting here in looking at the very edge, the scleral haptic here, if you look at the right eye, you can see how you have some bubbles and it's lifting. And same thing here with the left one, it's lifting. So this indicates that it's flat in the vertical meridian. And now when we look here at the horizontal meridian, you can see how we're getting compression of the blood vessels. So when we look at the scleral haptic of this lens, it's flat in the vertical meridian and steep in the horizontal meridian, indicating that this patient needs a toric peripheral system. So how to alleviate this? We went with a steep 2 in the vertical meridian and a flat 1 in the horizontal meridian. We also needed more of an oblate shape due to this patient being more post-refractive surgery. So we went with a 10.2 limbal curve. And since then, she's been doing great with the lenses. We've seen her back after several hours of wear, remove the lenses, instilled fluorescein stain, no staining. She's been very successful. This patient was a patient who was diagnosed with keratoconus over 15 years prior, who's currently wearing piggyback lenses, loves the comfort, doesn't mind the vision, but despises handling 2 pairs of lenses. Discussing the different options, said, I'm not crazy about trying the scleral lenses, but I will give it a go just because I hate having to deal with 2 pairs of lenses. The patient has asthma, sleep apnea, uses an inhaler as needed for the asthma and a CPAP machine for sleep apnea. Vision through the piggyback lens system is 20/50ths in the right eye, 20/40ths plus in the left. You can see high amounts of myopia, -16, -375, given only 22/100ths with refraction. Left eye -1450, -275, 21/50ths. Now this patient, the topographies are not great. You can see that we are missing a lot of information here. Part of that is because of poor tear film. He does have also some central scarring. And looking here, you know, these Ks are not accurate, but Ks are about 52 by 54 3/4, but highly irregular. Left eye, Ks are better. Ks are 65 by about 77. So highly irregular, poor tear film. And what we did with his is we did fit him with the lenses. You can see this nice 1-to-1 central relationship here. Great tear exchange. Patient immediately noticed improved comfort. First, he was pretty shocked at how to handle the lenses and wasn't sure if he wanted to go through with it. But in the end decided, I think because initially these feel so good and my vision is so much better, let's go with it. Now look here, you can see this patient had loose conjunctiva, but you can see he's getting some conjunctival bunching, or it's being pulled up into under the lens. So we did have to address that. You know, we usually say that we want about 150 to 250 microns of central clearance, so this may be a little bit excessive, but as we flatten the scleral haptic here, the central clearance did decrease by about 50 microns, and that was adequate. With some of our very, very advanced cones, I'd rather there almost be a little bit extra versus not, just because I don't want there to be any rubbing, but he has been doing just fine. Our last case that we're going to be going over is just to show how these lenses can be used for ocular surface disease. This patient is one of my favorites. She came in for a fitting. She was referred. She has Sjogren's syndrome, and as you can see, she has a whole host of different therapies that she's already on: Restasis, preservative-free tears, gels, ointments, autologous serum. She's tried bandaged contact lenses, moisture goggles, punctal plugs, and she complained of blurred vision, foreign body sensation, light sensitivity, and overall discomfort. And she had been discussed with the option of scleral lenses for over a year, and finally she had agreed to pursue a scleral fitting. Her entering acuity through her glasses was 20/25 at distance, 20/25 at near, 20/30 at distance in the left eye, 20/25 at near. Again, her refractive error was not that significant. Her corneal diameter was a 12.7 in the right eye and a 12.9 in the left. And here you can see that she has quite a bit of staining, but also she tends to get filaments. So here you can see her staining. So this was removed. And taking a look here, again, we see some artifacts, but we have about 260 microns of central clearance in the right and 230 microns of clearance in the left. Taking a look at the images, we have an acceptable fit centrally, that 1:1, and no blanching, impingement, or liftoff on the edge. And after only 1 month of scleral lens wear, we can see improvement. She still has a little bit of staining, but we do see some improvement. And up to, to date, the patient has been wearing the lenses for 1.5 years, and she notes a marked improvement in ocular comfort. She is finding that she does not need to use as many artificial tears. Her final lenses, we had to modify with a flatter edge. The patient is currently using Clear Care Solution nightly, but she's doing fantastic with the lenses. So these lenses, and I think when we're fitting these patients with ocular surface disease, it's important to talk to them that these lenses are not going to cure their problem. It's only going to help mitigate their symptoms. They're still going to have to use some of their other therapies, but it's used in conjunction with those. It's not going to cure them. It's just going to help alleviate and help hopefully heal some of their corneal staining, which in this case it did. So I hope that you found this discussion helpful. What we wanted to do is just to show you that the InSight has clinical applications for so many different types of patients. It can be utilized for patients with uncomplicated refractive error, patients with irregular corneas, those who have keratoconus, those who are post-refractive surgery, post-cross-linking. It allows for increased wearing time, reduces corneal staining, improves vision. It also has applications for those patients with significant dry eye, those patients with damage and diseased ocular surfaces. It can be really instrumental in reducing further corneal damage, as it serves as a tear reservoir to allow corneal healing and improved vision. I really want to thank you for your time and attention. If you would like additional information about the lens, about additional cases, you can look online at metrooptics.com. You can follow them on Facebook or Twitter. This webinar is going to be available on Metro's website. You can also look at the first webinar, and attendees can qualify for 25% discount on InSight products through August 31st. And if you ever have any specific questions about any cases, about lens, you can feel free to email myself or Dr. Neil Hoder, one of the other co-developers of the lens, at any time, and we will do our best to try to get back to you in a timely fashion.
Great. That was great information, Jen. I do have a couple questions from a couple people here. First was on the last case with the corneal surface disease. Just wondering what kind of solution you use to fill the scleral bowl, and if you can use artificial tears, would that help?
So I think those patients who have severe corneal surface disease, you have to take it on a case-by-case basis. Some of these patients are very sensitive, and some have severe allergies to different preservatives, to different medications. So you really have to take it and case by case and talk to the patient. If they're going to use artificial tears, you need to make sure that it's preservative free. You can use, the sodium chloride inhalation solution, Lacropure, Purolens some individuals use. I think what's also really important is to talk to the patient about how they're cleaning their lenses, and clear care, the hydrogen peroxide is definitely what's recommended. But artificial tears are appropriate as long as they're preservative free. And then some individuals will also put like a drop or two of their autologous serum into the bowl along with the artificial tears.
That's a good tip. And would you recommend HydroPeg for these?
Absolutely.
Patients?
These patients should have their lenses hydropegged. You'll also probably find that the patients who have the more severe ocular surface disease need to remove their lenses midday to clean and rinse and then refill their lenses with preservative-free tears and reapply.
Okay, good. Another one, I know this is a question about a lot of people with post-graft patients. I know a lot of people are worried about potentially causing graft rejections. Do you have any pearls on when to fit them after surgery, or routine follow-up care after the fitting?
Yeah, with post-grafts, they're very challenging, and you need to, again, work with the cornea specialist that you're co-managing these with. Usually they will give you clearance as to when they can be fit into lenses, and for some it's going to be after a year, some it may be a little bit earlier, 6 months. The key thing to look for with post-graft patients is we really should be measuring endothelial cell counts as well as corneal thickness. And if endothelial cell count is below 800, they should not be in a scleral lens at all, because that can increase hypoxia. You can lead to neovascularization. So some graft patients do really well in scleral lenses and others do not. And in a lot of instances, a scleral lens may not be the first lens of choice. It may do better with a corneal GP, and these patients should be watched pretty closely if you are fitting them in a scleral lens, just to make sure that you don't see any signs of rejection. So you initially probably want to see them, first month and then every 3 months, and you want to be in good communication with that co-managing specialist as well.
Okay, and then that kind of leads into this next question too about post-RK patients. One person was wondering if you still have the diurnal fluctuations.
Yeah, so sometimes you do have a little bit of diurnal fluctuation, and the reason why you have the diurnal fluctuation with RK patients is because of pupil size. And so pupil size changes throughout the day. So as the pupil size changes, especially at night, it's going to cause more severe aberrations because they're getting into that irregular astigmatism. They're seeing more of those scars. So corneal GP lenses are going to help improve vision, but due to the highly irregular cornea, they're often going to have an unstable fit. So sclerals, we found, improve the fit, comfort, and vision. And patients may have a slight diurnal fluctuation, but it's not to the degree as other vision correction modalities. So they may have some, but we don't tend to see as many with sclerals as we do with other types of lenses or as with glasses.
Okay, great. And one more here. Going back to the OCT and the imaging, how long would you allow the lens to settle before taking OCT images?
We recommend at least 20 minutes. I mean, we can see from that one case that we discussed, we didn't wait long enough, and that would have saved us an order. So definitely wait at least 20 to 30 minutes. Don't take it, right away after insertion. 20 to 30 minutes, that should give you sufficient time. And if you don't have an OCT, you don't need it, but just allow your patient to sit for 20 to 30 minutes.
Okay, good.
In office before you make that final recommendation that you need to modify.
Okay, well, very good. I think that covers all the questions that came through. I do thank you, Dr. Harthan, for everything today presented. Those are interesting cases. So this concludes part 2 of our InSight webinar series. Please consider joining us on August 22nd at noon or 7:30 p.m. Central Time for part 3, Troubleshooting the InSight Scleral. Registration is open on our website at metro-optics.com. Thank you to all of you who took the time out of your day to attend. We are getting done a little early for this session, so you can get back to clinic. Have a wonderful afternoon.
Thank you, everyone. Have a great day.